Thank you very much for reconvening. It gives me great pleasure to introduce one of the supervisors to give the lecture that was supposed to be given by the PhD student, who is now lobbying in Canberra for the greater good of attracting more funds for research in medical oncology for young researchers. So Adrian Lee is excused. Helen just came off the plane, so she's going to be brilliant. You're probably in your euphoria thing. Thanks very much.
Oh, thank you. I will apologise because my vision's a little blurry. I'm a little jet lagged, and saw this 2 minutes ago. Just as a little bit of background, about 30 years ago, I was conned into doing some lab-based research in the old Colling building before it was pulled down. And one of the reasons, we were looking at the association between coagulation, deep vein thrombosis, pulmonary emboli, DIC, and cancer. And it kind of went pretty well until we got to molecular biology. And at that stage, the only molecular biology was something called northern blot. That took about 3 weeks to prepare your samples, 3 weeks to incubate in the -70, and then you pulled it out to see if you had any lines on your X-ray radiograph to see if the mRNA had come up, and it'd be blank. And you didn't really know where you started and where you ended, what had gone wrong. These days you guys have got equipment coming at you, and it's much, much easier to do molecular analysis. But I spent all my time there on the neurosurgery ward because the place to find people with VTE were the glioma patients. Incidence of clotting in glioma patients is about 30% plus. They have a poorer prognosis once they've clotted, and there's a big issue that you can't anticoagulate someone who's about to have brain surgery. And even to this day, convincing neurosurgeons that warfarin is not a drug that should ever be used hasn't come. I've just come back to a patient who's been put on warfarin. So the hypothesis with Adrian's thesis is there an association between coagulation, angiogenesis and inflammatory pathways in high-grade gliomas. He's looking at the incidence of a backdated database to try and recognise patients that have developed VTE, and then to molecularly subcategorise those tumours. The Canadians came out about 3 years ago to say those patients that have got EGFR amplified glioma have a high incidence of VTE, and that is something that we think is wrong with our preliminary data. So why would cancers want to clot? Once you've activated the coagulation cascade, you develop activated enzymes from the fibrinolytic pathway, which allows remodeling of the microenvironment. It has a systemic effect on the rest of the coagulation pathway in patients, and it also activates local inflammatory macrophages and endothelial cells to develop new angiogenic modelling networks. So, as everyone knows, high-grade gliomas are bad. We haven't had any new therapies. The last drug was 25 years ago that came through on the PBS. And we've heard about a lot of different understandings with molecular biology, but nothing has come into the clinic for treatment of these patients. And the other group that have a poor prognosis and maybe doing slightly similar things, pancreatic cancer. It's been a challenging project for Adrian to try and find this retrospective data on who clotted, who didn't. Thanks to Anthony Gill, we had some TMAs up until 2012, and Adrian subsequently made TMAs up until the end of 2015, because the closer we get to that, the closer we can find out what is happening from a VTE point of view. And then as time goes on, we'll be able to work out who is at high risk, because the neurosurgeon certainly won't give prophylactic anticoagulants to their patients. There's an issue, will low molecular weight heparin is the drug of choice for these patients, and with the new NOACs, will they actually work in this situation? Because we think that the benefit of low molecular weight heparin is the release of tissue factor pathway inhibitor and potentially inhibiting coagulation at the cancer cell level, whereas these other, the NOACs actually are molecularly targeted to factor 10 and factor 2, and they might not have as much of an impact. So far, we've looked at the TMAs with the fish testing. He's found that 29% of them are amplified so far. We've got 21% of cases with VTE that we've identified, and we have not yet found an association with EGFR amplification in VTE. This is a work in progress. And we hope at the end of this to have about 500 cases we'll be able to associate. There's also the difference between if EGFR is amplified, there are other pathways such as UPAR, etc., that are going to be affected. So this will be an interacting molecular pathway that could be significantly changed. Interestingly enough, the low-grade tumours, that may well be anticoagulant, and in clinic we see that the low-grade tumours bleed. They would often present with a cerebral hemorrhage, and there's something in that as to how their genetics actually make them more likely to hemorrhage. So it's early days. Adrian's had some help from numerous people, collaborated with various people. As I said, Anthony's been invaluable in providing initial TMAs, and both Amanda and Angela in the lab have helped him try and collect sequential blood samples from patients to see if we can take a blood pre-op, post-op, and then use that to track whether or not there are changes that will make us be able to predict that these patients are going to clot. We're trying now to look at a whole lot of different antibodies. Certainly Liz in our lab has been helpful in trying to standardise those before we go and stain them. And the neurosurgeons, we're trying to get them to collaborate. All they need to do is pick up the phone and say we're taking someone to theatre to operate on a brain tumour, but it doesn't seem to be in their nature to do so. So work in progress. Thank you.
Thank you very much. This excuse answering any questions. So the next speaker is April Wong. April, on project working and sort of trying to get analysis on the data. Yes. Thank you very much for presenting.
Thank you. Is it on here?
I just need to push the mouse once.
Oh, there we go. Let me see. Okay. So yeah, wish today I'll be able to do a bit more reporting of analysis, but circumstances has arisen. I'll talk a bit about that. Yeah. So there's been a delay in analysis, but essentially this is a pilot study looking at the quality of life of women undergoing mastectomy with immediate delay or no breast reconstruction, as well as undergoing adjuvant radiotherapy for breast cancer. Oh, that's short. I couldn't call it. Bit of background for some of you who haven't heard of this study. I have presented a couple of times, but that's okay. So breast cancer, we know it's the most common malignancy in women. About 30 to 50% of women will undergo mastectomy as part of their breast cancer management. And there's been research showing that if women were offered reconstruction, about half of them will actually choose it. And currently, clinical guidelines all over the world have recommended breast reconstruction to all suitable women requiring mastectomy or choosing mastectomy. Our current national, or actually Australasian, breast reconstruction rate is still pretty low, sitting around 6 to 16%. We have centre differences. This is centre in Sydney, about 41%. Overseas, USA about 25, UK 21, and it can range from 5 up to 80%. There are barriers to reconstruction and associated factors. One of them being patients undergoing adjuvant treatments such as radiation and chemotherapy. because I guess traditionally it's been thought that this would interfere with delivering of radiation and also impacting the quality of the reconstruction if the patient it's undergoing radiation, and anxiety about delaying all these treatments if a patient does suffer surgical complications. So I guess, you know, a typical MDT scenario, we all have something to say about what we feel may be high risk for this patient, and anxiety about patient undergoing reconstruction, and ultimately this woman will be offered a simple mastectomy only. So these women will be the higher risk, I guess, in terms of the clinical situation, who will need adjuvant radiation and often chemotherapy as well. So traditionally for these women who, if they want to have reconstruction, they'll only be offered a delayed reconstruction. And we know that patients undergoing delayed reconstruction, a couple of things, that it may never happen, and whether due to lack of access, like in New Zealand the wait list could be up to 5 years, or that they wait for a period of time and they just give up and they say, oh, can't be bothered. So, and that could account for our low reconstruction rate as well overall. But currently we have quite a few now studies. There is a meta-analysis looking at the safety of breast reconstruction, and it has shown that there's no increase in frequency in detecting local systemic recurrence for patients undergoing immediate reconstruction compared to those undergoing mastectomy alone. And even for those in the who are undergoing adjuvant treatments, again, there's some studies now showing it does not impair in detecting recurrence, does not cause significant delays, with acceptable rates of complications and high levels of patient satisfaction. Benefits of reconstruction are many: improve psychological well-being, improves the woman's ability to cope with the negative consequences of psychological consequences, mainly of having a mastectomy, enhancing the quality of life. And so which leads on to the question how the study had come about. If immediate breast reconstruction improves quality of life for patients undergoing radiation treatment, other adjuvant treatments, then perhaps we should be offering immediate reconstruction to all breast cancer patients who are reasonable candidates for this procedure, and not deprived of the ability to choose. This is a slide courtesy of Professor Madeline King, the Director of the Cancer Care Quality of Life, essentially showing the multifactorial facets of cancer care, how each component, and whether it be the functional, the well-being, psychological, the surgical side, all has a flow-on effect to ultimately affect a patient's global health and well-being and happiness. And so the Hollis pilot design was essentially a prospective cohort observational study. We know, as with surgical studies, it's impossible to double-blind a surgeon, so we felt that this would probably be the next best option. Multi-centre being that we were able to just start off with the 2 centres, so the Breast Surgical Oncology Centre, Coast Centre, and in Waikato, New Zealand. It's essentially a series of surveys looking at various patient-reported outcomes at various time points, with an aim of having a minimum of 20 patients at each arm, and seeing what results we get at 2 years, though it's a bit longer than that now. But this is the first prospective study in Australia and New Zealand looking at women in this high-risk breast cancer group requiring mastectomy, plus or minus reconstruction, and adjuvant radiation therapy. This will help us understand women undergoing breast reconstruction, the timing, and why women choose one choice over the other, what are the barriers, the aesthetic outcomes, and obviously the safety of all of this. And hopefully we'll be able to provide some long-term social supports as well for women in these groups. So there are 3 groups in the study. There's the women in the immediate group, immediate breast reconstruction group, and the women, if they choose, they can choose. So with discussion with the surgeon, they can choose which group they want to be in, and there's a non-reconstruction group, and then there's a delay reconstruction group. So the aim is to look at the feasibility of the study, assessing a range of patient-reported outcomes. Similarly, looking at objectives. So One of the our hypotheses is essentially that that patient-reported rates will be high and patients are willing to participate, and that maybe immediate breast reconstruction will provide better patient-reported outcomes across a range of issues, and that immediate breast reconstruction does not significantly delay the delivery of adjuvant therapies. These are our main domains of interest, mainly quality of life, body image and pain. And these are our surveys that we're using, or the outcome measures that we're using: ERTC, C30, PR23, breast-Q, mastectomy reconstruction module, body image, pain, inclusion and exclusion criteria. So adjuvant radiation treatment, it will be through the multidisciplinary team approach and what's current evidence. Our 3-month analysis, which we did do last year, and I presented at the ANZ Breast Cancer Trials Group, the results were early and the numbers were small, but the trends were all similar across all the 3 groups, and that it's shown that with the patients in the IBR group, there was no immediate harm seen. So the conclusion of that was perhaps we can still continue to see, and the idea was we were wanting to wait for the 12-month analysis. And so this year, we've compared it, so our numbers so far, we've got a total of 92 patients. I think that's got quite a good number. I think that's probably one of the bigger numbers in the literature of women who's had mastectomy and radiation treatment and undergoing plus or minus reconstruction. So in the immediate group, we have about 58. Delay group, it's been hard to recruit through a number of factors, and the NBR, the non-reconstruction group, we've reached our 20 mark. So we have decided to stop recruiting this year, April being our last patient. So the decision was to decide whether we do a 12 months analysis now, and as you can see, if you just look at the 12 months column, we have only about half of those time points available, and because our numbers are so small, we just felt that you know, it will be a loss and a lost opportunity if we didn't wait just for the extra 12 months just to get the full set of data to ensure that we collect all the data points necessary to find any differences for this pilot study, as we don't have big numbers to start with. So that's where we're, so the plan for the 12 months analysis is actually next year, April 2017. We have ceased recruitment into the pilot study, and I guess we'll wait and see what those results show with bated breath. Thank you.
So, can I just ask you, what do you think are the barriers for surgical research?
Barriers of surgical research. From a surgical point of view, or from?
That's more from surgical point of view.
Yeah, I guess, as we know, the epidemic of research is our level 1 randomized controlled trial, and from a surgeon's point of view, you can never double blind a surgical procedure. So that in itself, if you can't do that, the critics will always say there will be biases. And I guess depending on how you look at it, you can look at all the surgical operations that we've ever done. Sure, probably in the last decade we've put some evidence and p-values into surgical, our work, but back when we had to do a laparotomy, we just did a laparotomy. There was no evidence on doing it this way or that way. We just sort of did it, and we get to the long-term results. We know that that's safe. So sometimes I think with surgical research, I guess the prospective trial and with large numbers will be, I guess, the next best thing. And knowing that there will be biases, and maybe we may have to accept that.
So it could also be that maybe in surgery we really know what, but that we actually don't know why. So it could be that we're missing the boat by not sort of incorporating genomic or other analyses in our randomized trial.
Again, certainly with the genomic testing and everything, that's advancing. It's happening sort of really in the last few years, and it is changing the face of research in many fronts. So incorporating that will, certainly determine how we will practice in the future.
Thanks. Thanks, Edward. So the next speaker is Angela Cho, speaking on tumor-educated platelets. Quite different from tumor-educated patients.
So hello, my name's Angela and I'm a first year PhD student. So this proof of principle project aims to improve patient outcomes in a specific type of brain cancer. So this funding was awarded to Viva Howell and this forms the first part of my PhD. So what I want to look at is tumor-educated platelets, also known as TEPs, and determining whether or not they can be used as a biomarker to monitor progression in glioma. So glioma is the most common primary brain tumor in adults, and they can be separated in two groups based on their aggressiveness and also malignancy, which is low-grade and high-grade gliomas. So low-grade gliomas encompass grade 1 and grade 2 gliomas, and the median survival ranges from 5 to 10 years, whereas high-grade gliomas encompasses grade 3 and grade 4 gliomas, and the median survival ranges from only 12 to 18 months. And the 5-year survival is less than 10%. So I'll introduce two major problems which is widespread in the clinical setting, and these problems form the basis of my project. So the first problem concerns how the patients are treated. So the standard treatment of care for glioma patients involves surgery, radiotherapy, and also chemotherapy. However, no matter how aggressive this treatment is, treatment for glioma is not curative. Now this problem goes into my second problem, where progression and recurrence is inevitable. And the most common cause of mortality in glioma patients is actually due to tumor recurrence after treatment. Now these problems highlight not only the need for better treatment, but also the need for better monitoring of patients. Now, because treatment is not curative and progression and recurrence is inevitable, this means that our number one priority is patient management. So MRI and CT imaging is routinely used to monitor patients. The major clinical problem is actually interpreting these MRI scans following treatment. And this is because acute radiation change can mimic tumor recurrence, and this is often termed as pseudoprogression. Now I'm going to show you an example of why this is a major clinical problem. Now this first image here is an MRI of a patient pre-treatment with the glioma circled in red. This second image here is another MRI of the same patient 1 month post-treatment, and you can see the mass has actually enlarged. Now this enlargement can mean one of two things. It can mean pseudoprogression or actual progression. Now this third image here is a classic example of pseudoprogression. So this third image is an MRI of the same patient 1 year post-diagnosis, where the patient did not receive any treatment from the second to third scan. And you can see the mass has actually gotten smaller. Now what this means in this case is that this enlargement in the second scan is actually just due to treatment-related effects like edema or inflammation. And this actually mimics true tumor progression. However, the second scenario would be that it is real tumor progression. Now, this happens all the time. I attend neuro-oncology multidisciplinary team meetings every week where it involves oncologists and also radiologists, and then it discusses these interesting cases. And pseudoprogression is a common occurrence. So pseudoprogression takes up to 6 months to resolve. So how can you differentiate between the two? You basically can't. So when clinicians are faced with this problem, would they continue therapy or stop therapy? They wouldn't want to subject a patient to further treatment when it's not beneficial to them. So this highlights why imaging-independent methods are needed to differentiate between pseudoprogression and real progression. So this is why I'm looking at tumor-aggregated platelets, also known as TEPs, as an imaging independent method to determine whether this is pseudoprogression or real progression. So TEPs are formed when the tumor cell releases packages of genetic material in the form of macrovesicles or exosomes, and then these are then fused or endocytosed into a platelet, and this is how the platelet becomes educated. So we are looking at TEPs because they have been found in other cancers to take up tumor-specific mutations and also genetic material. And then they were able to distinguish cancer patients from healthy individuals. The cons of this is that these papers were only looking at high-grade cancers. Now, since this is a proof of principle project for our model, we are looking at patients with a known IDH mutation in their tumors. Now, IDH1 tumors are a subtype of glioma, and the majority of IDH1 mutant gliomas are a subtype of low-grade gliomas, which eventually progress into high-grade. So this is like a perfect example of recurrence. So IDH mutations is an ideal mutation to look for because it is an early genetic driver, and it is also glioma specific. So in terms of detecting the IDH1 mutation, I will be taking blood from patients with a known IDH1 mutated glioma. And to help me do this, I'll be working very closely with neuro-oncologist Helen Wheeler and also neuro-oncology nurse Marina Castellan, who would be taking the blood for me. Then I'll be extracting RNA from the platelets and then measuring the amount of transcript using droplet digital PCR, and then correlating the amount of transcript detected with disease status. So I would hypothesize that pseudoprogression will have little or none transcripts detected in the platelets, and real progression would have a higher amount of these IDH1 mutations in these platelets. So it's still in its early stages, so I've successfully isolated RNA from platelets from both normal and IDH1 mutant patients, but then I have not detected the mutant yet because I'm still optimizing the protocol. But then I would hope that these TEPs have a potential as a tool to help clinical decision making. Thank you.
Early stages, but well done. So are there other tumours or tumour streams that where there have been clinical trials or where there has been clinical information? Other tumour types? Do you know?
Of
TEPs are...
they have done glioblastoma, but then we're looking at low grade. So there's no point having a biomarker for high grade.
But in any other tumour streams?
Oh yeah, lung, breast,
yeah,
colon.
Specific? Are they sort of good markers?
Yeah, KRAF and EGFR as well.
What about neck tumors?
No, I haven't seen that yet, no.
Good. Thank you very much. Thanks. So the next one is Chris Nam, and he'll talk about prognostic tumor biomarkers in PDAC. Working with Annabelle Patel and Jessica Mountain.
Good afternoon, everyone. Thank you for the opportunity to present my work. My name is Chris Nam. I'm one of these fellows in the upper GI surgical unit here at Royal North Shore Hospital, and also a first-year PhD student with the Bill Walsh Cancer Research Laboratory. We know that pancreatic cancer survival is very poor. This is a Kaplan-Meier survival curve of patients who have been offered and given pancreatic resection for localized pancreatic cancer. This is data from over 1,000 patients from Johns Hopkins University. And as you can see, there's a steep decline over the first 12 to 24 months. In Australia, this affects 2,500 new patients every year. There's a 5-year survival of 5%, which has seen very little increase or improvement over the last few decades. Most patients will present with unresectable disease on account of their local advancement or distant metastases. A minority of patients will have resectable disease. However, despite surgery, 35% of patients will have a 1-year mortality. And at 2 years, 65% of patients will have mortality after resection. With regard to the surgery itself, this video has been provided courtesy of Professor Jasminder Samra, pancreatic surgeon at Royal North Shore Hospital. This is a part of the operation after the tumour has been resected and the pancreas has been rejoined into the small bowel. And this just one part of the operation accounts for a significant proportion of morbidity and mortality associated with pancreatic cancer surgery. This is because the pancreatic fluid that emanates the pancreatic duct is enzyme rich, and when it leaks into the abdomen, which inevitably does in a large proportion of cases, it starts denaturing a lot of the proteins around key anatomical structures, including large blood vessels. This leads to the clinical catastrophe of catastrophic intra-abdominal hemorrhage and also intra-abdominal sepsis. At best, patients will experience a 2-week stay in hospital and then a 2 to 3 month recovery either at home or in an inpatient rehabilitation facility. And of course, from a long-term perspective, will have to endure the consequences of pancreatic, endocrine and exocrine insufficiency. Therefore, it's clear that not all patients who are offered pancreatic cancer resection derive a significant oncological benefit from this procedure. There is a need for careful patient selection. This means identifying the patients who will have the best surgical outcome, who will derive the most oncological benefit. In terms of identifying those who will have the best surgical outcome, we look at their age and their comorbidities. In terms of looking at those who will derive the most oncological benefit, we look at the relationship of the tumour to key anatomical structures, is it resectable, and also whether there are or are not any distant metastatic disease. However, with this state of play, we are unable to predict a number of oncologically significant factors, including the presence of micrometastatic disease, perineural or lymphovascular invasion, lymph node involvement, and this translates loosely to a likelihood of early recurrence. This is where we need a window into the biology of the tumour, and this is where tissue biomarkers are playing a role. There has been a recent explosion in the number of biomarkers reported in the literature of prognostic significance in pancreatic cancer. This is a systematic review that our unit published, reviewing that literature. We looked at 256 biomarkers and which were identified in 158 studies. These biomarkers were assigned a remark score, which is correlated with the level of evidence with which it's reported. And this is a table demonstrating the top biomarkers with the highest remark score, therefore highest level of evidence, shown to be of prognostic significance. We have chosen 10 of the highest scoring remarks criteria biomarkers and used them as a panel which we choose to evaluate in our pancreatic cancer cohort. Interrogating publicly available TCGA data with these biomarkers, we can see that there is a clear difference in patients who have at least one mutation in these biomarkers compared with those who do not. Therefore, we hypothesize that a panel of immunohistochemically detectable biomarkers can be used to identify a pattern of gene expression in pancreatic cancer tissue correlating with oncological outcome, thus allowing a prediction of which patients will benefit most from surgery. We aim, therefore, primarily to validate the prognostic utility of this panel as a prognostic tool, and secondly, to identify a biomarker pattern in the tumour tissue of pancreatic cancer patients who don't gain the survival advantage from surgery. This is an observational study of 200 patients for which tissue microarrays are already available. It will involve correlation of clinical, operative and pathological data with biomarkers, and the biomarkers will be detected by immunohistochemistry because primary antibodies are available for these biomarkers. So far, this is just a figure that demonstrates some of the optimization work that has been done with the assistance of Liz Miller, Emily Colvin and Viva Howe from Bill Walsh. The optimization of all 10 antibodies is now complete. All the operative, clinical and pathological data has been collated, and we now need to commence staining the actual TMAs, scored and statistically analyzed. This is part of a broader disciplinary conversation regarding cancer research. Clinically, we are aiming to answer the question of whether we are operating on the right patients, and also can we improve on the outcome prediction in multidisciplinary settings by looking at the biology of the tumour in addition to what we are looking at already. Scientifically, this is a response to a surge in recent biomarker discovery aided partially or significantly by recent genomic consortium data. It also evaluates the utility of a panel rather than individual biomarkers, and it's a proof of principle project that may lead to validation of these biomarkers in preoperatively obtained tissue. With regard to Sydney Vital Translational Research Goals, this is practice improving research. It is validation of a commonly used technique in the clinical realm, and hopefully this will lead to rapid translation into the clinical setting. It integrates tumor biology into the decision-making algorithm, which currently is not the case. And hopefully this will lead to improved patient outcomes by avoiding unnecessary surgery and morbidity, and referring patients to the most appropriate treatment modality for these patients, which may not necessarily be surgery, which is difficult for a surgeon to say. But this is a large collaborative effort, including those surgeons from the upper GI surgical unit, scientists and oncologists from the Bill Walsh Group, Professor Anthony Gill from Cancer Diagnosis and Pathology, and I'd like to acknowledge the funding sources from Sydney Vital and scholarships from University of Sydney and the College of Surgeons. Thank you.
So this is the future for surgery? Surgical oncology?
As much as I hate to say it, I mean, from a surgical perspective, if this does prove to be the case, it may well decrease the number of surgeries that we do, and it pains me to think that, you know, in several decades' time when I do become a consultant, that will be the reality of pancreatic surgery. But I think on the flip side, it will mean better outcomes for patients. Currently, this project, I sort of think that it's fairly small scale. I hope from a broader sort of perspective, biomarker discovery will actually detect more of those key driving mutations that can be actionable and lead to better survival for these patients.
Can I just ask, are the biomarkers based on the 1-year survival? Are they based on the 2-year survival? Are they based on 5-year survival? Because evidently you have very low mortality rates in the first 2 or 3 months, i.e. you do very good pancreas surgery. Maybe that influences the clinical importance of biomarkers?
That's true. I think by this being a sort of a single center type of project, that imparts a kind of homogeneity to the surgical outcomes on the patient. And currently we know that the best thing for these patients, because systemic therapies for pancreatic cancer are so poor in their efficacy, that the best thing for these patients is to have best surgery. And so this being a single center type of project kind of imparts some consistency to that, but it's difficult to answer that question.
So I was wondering, have you given any consideration to the functional significance of the biomarkers, or is it at least entirely empirically developed just based on outcome data? In other words, it'd be nice to know what pathways those markers are pointing to.
Yeah, in that table that I showed, it did sort of vaguely correlate them with sort of gene ontology type processes in sort of cancer tumorigenesis, but the list has been derived just by looking at level of evidence rather than looking at specific pathways.
Thank you very much.
Thank you.
Thank you. We're going to Yasser Golani, who is now in his 3rd year as a PhD for their project. Yep. Starting to think about writing a thesis. And he's going to talk about spinal. Yes.
Hi everybody, my name is Yasser and I'm a PhD candidate at the School of Physics at University of Sydney, and I've been working on developing theranostic supraparamagnetic iron oxide nanoparticle, which is a long name, for multimodal molecular imaging and targeted radionuclide therapy. And this project, it's been in collaborations with MGH Medical Center and also the University of Harvard, and actually I'm going to MGH next week to meet with our team over there and share our recent results. So let's start with this question: why nanoparticles? Why theranostic nanoparticle platforms? So one of the main challenges in the field of nuclear medicine currently is the cancer staging, or detecting small metastases or micrometastases. And although the current imaging modalities such as PET and MR to some extent has overcome this issue, but still there are a lot of room for improvement. For example, if you look at this conventional MR scan, which is using a normal nodal abnormalities in a patient with prostate cancer, the scan suggests that the whole region there is cancerous, and I'm going to show you in the following slides that this is an inaccurate characterization of metastasis in the lymph node. And so basically my study and our goal was to develop a theranostic nanoplatform which has nanoparticles. It has labeled with a PET tracer, and using the magnetic nanoparticles to combine a PET-MR contrast agents for PET-MR imaging, and also at the same time having a therapeutic or theranostic isotopes for actual simultaneous therapy and imaging. So for that purpose, I have tried these protocols that I have developed for different type of nanoparticles with different polymer size, polymer type, and magnetic core size. And of course, our major interest was on ferriheme nanoparticle, which is the FDA-approved drug for treating iron deficiency. And the recent clinical trials and clinical research has shown that ferriheme can be actually used as a negative MR contrast agent for imaging lymphatic metastasis, and also for imaging macrophages. So that's for the passive side of imaging. But also recent study has shown this actually ferriheme can have an uptake on solid tumor. So you can actually have a targeting imaging and targeted therapy as well. So the first step really is to establish a radiolabeling platform which creates a high radiochemical yield and high radiochemical purity with different range of isotopes, and also characterize them. So I've been radiolabeling these nanoparticles with heat-induced radiolabeling technique, which is completely chelate-free. So that's kind of a big advantage with current radiolabeling nanoparticles or antibodies or whatever the radiopharmacy is doing. So that's a major advantage of this technique, and also it's very cost-effective. So it doesn't really cost you much to prepare a 1 milligram for a patient for diagnostic or therapy. So for that purpose, I have radiolabeled these 3 nanoparticles with zirconium-89, which is a PET tracer with really high radiochemical yield and radiochemical purity. And ferriheme is actually performing really well, 92% and 97% for radiochemical purity. And I have developed 2 different type of protocols for radiolabeling lutetium-177 and yttrium-90, which is lutetium is a theranostic isotopes, can be used for SPECT, MR imaging, and also using the low energy beta emitters for therapy. And also I didn't have enough space and time to put the data for yttrium-90 ferriheme here, but we've done yttrium-90 ferriheme as well with radiochemical purity of 95% and 98% of radiochemical purity, which is amazing. So also I've been doing a lot of simulations, Monte Carlo simulations, and also quantum chemistry simulations to investigate the localization of these nanoparticles within the localizations of your radioactive isotopes within the nanoparticles, and also to look at the binding stability and all that sort of characterizations. And amazingly, we get about like 100 to 120 radioactive isotopes per nanoparticle, which is, again, it's another advantage compared to other type of targeting nuclear medicine therapy, which is, for example, if you're using peptide therapy, whatever, it's a very small molecules and you have a very small loading capacity per nanoparticle, this is again another advantage. And also I've done a lot of other experimental characterization using transmission electron microscopy and NMR to actually characterize these nanoparticles further. So here's just a simple test doing just proof of principle, looking at a phantom study. These are for the 10 and 25 nanometers radiolabeled nanoparticles with a PET tracer. I've been trying to investigate the different range of concentrations and different range of activities that we can image. And as you can see, we can get a detectable signals for PET even at the lower concentrations. And also here's the ferriheme nanoparticles. And also it's interesting, you can see a CT scan having these nanoparticles, it can actually work as a CT contrast agent as well. And that's basically because you have a relatively high density compared to water. So it's really got multifunctional purposes. And here's a lutetium ferriheme. It's a CT spec image, and also we investigated at different range of concentrations for that. And here's the MR images, and in terms of, I know you're all clinicals and I'm a physicist and you want to kind of think about how this is going to make sense for a patient. So if you remember that image that earlier I showed you with that lymphatic metastasis, this is pre-injections of ferriheme nanoparticles, this is post-injections. And as you can see, those regions completely gone into, and it looks completely dark. That's where actually you've got your nanoparticles. And you can only see you've got two hyperintense, and that's your metastasis. And the reason for that, I'm not going to confuse you with the physics behind it, is basically those nanoparticles under external magnetic fields, they become magnetic, they make their own magnetic field, which will protect the local magnetic field, and therefore that will affect the precessions of the proton of water molecules around the nanoparticles, which will shorten the T2 or the spin relaxation, and that will darken the image. So in terms of therapy also, this is another advantage of using this, because we can actually localize the energy deposition highly, because the emitted photons from the lutetiums can interact with the high atomic number of core, and that also will emit Auger electrons, which are high linear energy transfer, which means if you have that in your cell, within the cell nucleus, I will guarantee the cell is gone. So that's how highly it could damage the cell. And so just to summarize, I think, or I believe that this study will definitely open up a lot of avenues for different type of research, like radioimmunotherapy, internal radiotherapy. Especially, it will be very useful for actually diagnosed for the imaging the lymphatic metastasis of different type of cancer. And so I've just finished finalized our phantom study at Monash. I just came back yesterday, and here's the facilities down there. We successfully finalized our experiment, phantom experiment. It went well, and so that's Richard. He's helping me with the PET-MR images. And then I would like to thank my supervisor, Sedenka, Professor Dale, Stephen and Roger, and also the radiopharmacy group for their support, Nicholas, Ali, Graham, and that's me. And also I would like to thank Roselle, the Bill Wash lab manager, for giving me space at her lab. You can't imagine, I've done some engineering in a biological lab, so that's amazing. So every time I ask her, do you have this? They have it. And if they don't have it, I have enough materials to make my own. So that's amazing. Thanks a lot to Brazil and the Bill Wash Lab.
Question for, yes. So obviously, yes, the lymph node metastasis detection and treatment is of paramount importance in solid tumors. But specifically, if we can sort of base our pre-surgical decisions on a proper diagnosis, exactly. What do you think will happen with your technique?
So, I mean, what do you mean?
In terms of increasing the specificity and the positive value for lymph node metastases in, for example, colorectal cancer?
Yeah, so I think, for example, you might actually, so first of all, as I said, the first benefit would be to have a better and more accurate detection. So, you don't need to actually do a surgery to take the whole lymph out. So, or in terms of therapy, because this is going to be a more localized and targeting therapy, so it will be much more effective than external beam radiotherapy or other type of treatment. And actually, we're going to try the animal model next year at Monash. So we just start, preparing for that. But I'm sure this would have a definitely great advantage for not only lymphatic metastasis, but it could have other kind of usage for treating cancers and imaging cancers.
Thank you. Yes.
Thank you.
So penultimate is Alex Cole, and he's talking about targeting chemo-resistant cancer stem cells in ovarian cancer in collaboration with his supervisor, Dr. David Marsh. I think also it's the third year?
Yeah, that's right.
Yeah.
So hello everyone. So my professors for this work were, my supervisors for this work were Professor Deborah Marsh and Associate Professor Roderick Clifton-Bly from the Colling Institute, and I also had collaboration with Associate Professor Ronald Buthonovic from the University of Michigan, who I was lucky enough to go over there and work for about 4 months to learn some cancer stem cell techniques. So ovarian cancer is the 7th most frequently diagnosed female cancer worldwide and the most lethal of all gynecological malignancies. So the problem with this disease is that although initial response rates can be as high as 80%, recurrent chemo-resistant disease occurs in approximately 70% of all cases and can cause 5-year survival to fall below 25%. And that's really highlighted here in this graph, which shows a typical clinical course of ovarian cancer as a function of the CA125 levels, which is a indication of the growth of the tumour. So essentially the patient upon initial diagnosis is treated with a chemotherapeutic and goes into remission. However, within about a year they relapse and the tumour is now resistant, so they have to use a second therapy. The patient goes into remission, then relapses, and this continues until the patient dies, usually around 4 or 5 years. So a subset population of cancer cells termed cancer stem cells have been attributed to this innate chemoresistance. Essentially, within an initial tumour, you have a small population of cancer stem cells. Now, upon the chemotherapeutic treatment, the majority of this tumour will hopefully respond and it will die off. However, what's left are the cancer stem cells which are able to survive. So they're able to repopulate the tumour, and as a result, the tumour recurs and the patient relapses. So ovarian cancer stem cells can be identified using the 2 marks, aldehyde dehydrogenase, which is an enzyme, and prominin-1 or CD133, which is a bona fide stem cell mark. So the aim of this research was to understand and overcome mechanisms of resistance in ovarian cancer by targeting these cancer stem cell populations using the epigenome. So the addition of the 8.5 kilodalton ubiquitin protein to lysine 120 on the tail region of histone H2B is a very important epigenetic modification which can regulate gene expression and DNA damage. It's catalyzed by a number of E3 ligases, the most important being RNF20, and it's removed by a number of deubiquinases. This modification has also been shown to be very important in stem cells where in both mesenchymal and embryonic stem cells, this modification is at a relatively low level. However, upon its differentiation, for example, into an osteoblast, it dramatically increases. Now, it was shown that if you stimulate the cell to differentiate, however, you knock down RNF20 and thereby prevent this increase in H2-Bob, you actually prevent the cells from differentiating. So based on this research, we hypothesized that it could also be important in cancer stem cells, and we wanted to investigate this, and we thought that perhaps in the cancer stem cell populations, H2-Bob would also be low as it was in the mesenchymal and embryonic stem cells. So the first set of experiments we did was to isolate these cancer stem cells. We did that using fluorescence activated cell sorting, and we were able to isolate the 4 different populations. We then looked at the RNF20 expression, which is the E3 ligase responsible for this modification. We were able to show that it was lower in the cancer stem cell populations. So we then conducted Western blots on these 3 different populations, and unfortunately it turned out that, so plotting for H2-Bob, total H2B was just the total histone protein we used as control, and then beta-actin. Essentially we showed that for some reason this modification was lost when we put the cells through the flow cytometer, so we couldn't actually use the FACS to study this anymore. So to get around this, we decided to grow cells as, these cells as spheroids. So we used the 2 ovarian cancer cell lines of CAR4 and CAOV3. We grew them up as spheroids, and recently it's been shown that by growing cells as spheroids, you actually enrich for the cancer stem cell populations, mainly ALDH. So we grew them up for about 14 days, and we were able to show that we did get a significant increase in the ALDH positive population for both cell lines. However, we also got a significant decrease in CD133, which was surprising. So taking these now enriched cancer stem cell spheroids, we're able to compare them to cells just grown on a monolayer, so 2D, and we're able to show that there was a significant decrease in the levels of H2BUB, so H2B monoubiquination, in these cancer stem cell enriched spheroids. We also went and isolated the CD133 positive cancer stem cell mark and compared it to a negative population, and we're able to show that they also had a significant decrease in this epigenetic modification. So essentially this has shown that cancer stem cells have seem to have a lower expression of this epigenetic mark. And we were interested to take this a step further and actually see if we can by modulating this mark we can affect those populations. So we hypothesized that by knocking it down we'd be able to prevent these cancer stem cells from differentiating, and as a result these populations should increase. So to do that we used a short hairpin RNA against RNF20. So we have a vector shRNA1, shRNA2, B and C for 2 cell lines, and we're able to get a nice knockdown around 80%, and you can see we got the decrease in H2BUB, which we were interested in as well. So using this knockdown model, we then put the cells through a flow cytometer to analyze the populations, and we're able to show that in fact by modifying H2BUB we did get an increase in the ALDH positive population for both shRNAs, and we also did see this decrease in CD133, which is the other mark, and we saw this in both cell lines, which was surprising. I guess the main takeaway message for this was that H2BUB did seem to be important for cancer stem cells, and it does seem, and by regulating it, you are able to modify these cancer stem cell populations. And what was striking, what we're seeing here looks very similar to the pattern we were seeing when we were growing the cells as spheroids. So we decided to grow these shRNA knockdown cells as spheroids, and we're able to show that the two knockdown models were able to produce larger spheroids and more numerous spheroids in both cell lines. So in conclusion, this research is the first to report the ability of the epigenetic modification H2BUB to regulate ovarian cancer stem cell populations. We believe this epigenetic mechanism may be exploited to target ovarian cancer stem cells for therapy. I just want to acknowledge everyone from the Functional Genomics Lab, Cancer Genetics, the Bogdanovic Lab in Michigan, and my funding sources. Thanks.
Any questions? Good. So how long will it take from the step of identifying your marker to a clinical application? What is your
I think there's a big gap there. There's quite a bit of research that still needs to be done. Yeah, but I mean, I think there's definitely potential. It just needs more work.
Debbie, what do you think? Suppose you would get this to work, and this would prove a viable pathway to this, to go to.
Whether or not it would be viable, I'm not sure. There are cancer stem cell therapies which, as far as I know, they're only looking at using in combination with other drugs. As a standalone therapy, probably not. It would be nice. But,
I think epigenomic-based therapies definitely they're not being thought of as standalones, but in conjunction with other more standard therapies, and I guess particularly with DNA damaging type therapies, which is what is given as standard of care to ovarian cancer patients now. But as Alex has pointed out, that's not good enough. So we're looking at ways to basically increase that, and this is the kind of basic science that will underpin successful future therapies.
But if you look at this evidence, wouldn't it be better to just dramatic start at the stem cell level? You could do that because you then prevent maybe the recurrence, which I think makes more sense than waiting for the recurrence to happen. For example, or
this isn't what I would want to ask, but I guess that the problem is that the stem cells are selectively chemo and radio resistant, which makes them much harder to target than the rest of the population. I assume you were expecting CD133 and ALDH to sort in parallel. Was that right? And what's your take on that sort of divergent expression?
When you say sort in parallel?
Right, to co-express, is that right?
Look, they do co-express. It just I mean, we're using obviously cell lines which don't really reflect what you see in primary tumours. I mean, we do get double positive populations, so we do get co-expression of CD153 and ALDH, but this makes up probably 1% to 0.1% of in a patient. It's as low as that, but in the cell lines it's a bit higher. So we did see it a bit, but not a huge amount. And the decrease in CD133, we weren't really expecting to see that. But both of these marks can be used by themselves to define much more aggressive tumours, ones that have that are more chemo-resistant, that metastasize faster. So I think even by themselves they're very good marks. And I know
define in different populations from what you're saying, whereas you thought they would define the same population.
Yeah, that's right.
Thanks. So the last speaker, hi everyone, who's working with Dr. Tom Yu, and this is a project on colorectal liver metastases. Correct. And
unlike the program might suggest. Thank you, Alexander. My name's Kai Brown, and I'm a surgical registrar and PhD candidate. I'd like to thank Sydney Vital for their support for this project, which is entitled Stromal Biomarkers in Primary Metastatic Colorectal Cancer. Just a bit of background. You'd all be aware that colorectal cancer represents a huge burden of disease in Australia, being the second highest cause of cancer death, and that's most commonly from metastatic disease to the liver. More recently, amongst a broader effort to individualise cancer management, there's been a handful of molecular markers that have, such as MSI status, KRAS and BRAF status, that have started to become integrated into synoptic reporting and prognosticating and tailoring an individual patient's treatment. Despite this, for a large proportion of intermediate stage patients, the current AJCC staging criteria fails to accurately predict their subsequent risk of metastatic disease. Similarly, the parameters by which we determine a patient's risk of recurrence and likely survival following resection of colorectal liver metastases is really still quite rudimentary. And this overall has a huge impact in decision making in the management of a patient with intermediate or advanced colorectal cancer. So our understanding of why two tumours of similar clinical and histological characteristics might have very different clinical outcomes sort of took a major step forward about a year ago when 4 consensus molecular subtypes of colorectal cancer were defined in a seminal Nature paper. In particular, the second most prevalent subtype, which was denoted CMS4, consistently stood out as that with the highest risk of recurrence and metastasis, independent of any clinical, histological features or MSI or KRAS or BRAF status. It's characterised by a transcriptomic signature of genes implicated in EMT, activation of TGF-beta signalling, angiogenesis, matrix remodeling, and the complement-mediated inflammatory system. In addition, the CMS4 subtype exhibits a gene expression profile compatible with significant stromal infiltration. This notion or observation that colorectal tumours that have high stromal content have poorer clinical outcomes is by no means novel, but amongst the increasing recognition of this role of the tumour microenvironment in cancer biology, the stromas increasingly becoming an attractive target due to its relative genetic stability and abundance. With respect to the CMS4 subtype, it's still a matter of debate whether the mesenchymal appearance is caused by epithelial cells that have undergone EMT and thus acquire a mesenchymal phenotype, or rather by the presence, solely by the presence of excess stroma that may have a higher activation state. And furthermore, whilst there's in vitro evidence that cancer-associated fibroblasts are important for colorectal cancer to survive in a metastatic niche such as the liver, there's actually no data that characterises the metastatic tumour-associated stroma with any significant resolution or describes its relevance on clinical outcomes. So this led me to ask a question: what characterises stroma of poor prognosis primary colorectal cancer patients, and how are these characteristics preserved in their subsequent liver metastases? So to address this question, I bridged 3 independent databases from various departments at the Royal North Shore campus, including HPV surgery, colorectal surgery, and anatomical pathology. I leveraged the fact that at Royal North Shore, many patients who undergo resection of their primary tumour will also be managed here if they subsequently develop colorectal liver metastases, and that almost all the surgical specimens are processed through Palms pathology, whether they're operated on in the public or the private. So after updating clinical data and cross-matching hundreds of patients, I identified a nested case control cohort from which I created tissue microarrays in order to investigate the prognostic value of a panel of 6 potential stromal biomarkers which I identified from the literature. I also selected a subgroup of this cohort for a deeper gene expression study where I separate the epithelial tumour compartment from the tumour-associated stroma in primary colorectal cancer and match colorectal liver metastases, as well as a control group, to examine the expression of genes known to be involved in matrix remodeling, angiogenesis, EMT, and metastasis. And the final results of these 2 components are pending. So the translational aims of the project were really to understand the longitudinal longitudinal evolution of the tumour-associated stroma in primary colorectal cancer to liver metastasis. Secondly was to identify hopefully targetable pathways between epithelial colorectal cancer cells and tumour-associated stroma that might be significant in the process of metastasis and recurrence in advanced colorectal cancer. And finally, to identify novel stromal protein biomarkers to better identify patients most at risk of metastasis or recurrence after resection of primary colorectal cancer or liver mets. So how do these aims fit into the sort of broader research context? Well, some authors have shown in vitro and in mouse models that malignant cells are dependent on signals from activated stroma for survival in the metastatic niche, and that activated stromal cells may even accompany or even precede cancer cell seeding, say for example in the liver. Conversely, others have shown that only malignant cells that induce stromal activation in distant organs are able to colonize in that site. So that allows the speculation that maybe malignant transformation of epithelial cells shapes the stromal microenvironment. In a number of recent review articles and opinion pieces, authors have identified the need to understand whether or not malignant cells remain dependent on microenvironmental stimuli throughout the development, through their progression into metastatic disease. And they've also identified the obvious therapeutic potential, not just in colorectal cancer, but in other tumour streams, of targeting the stromal microenvironment to potentially render metastases unviable or even prevent metastatic seeding altogether. So therefore, I think by addressing some of these current issues in this particular context, specifically in clinical samples, both at the transcript and protein level, and importantly supported by strong clinical data, this project will facilitate the generation of hopefully practice improving research and its integration into clinical practice. So thank you for inviting me to speak, and thank you again to Sydney Vale.
Any questions?
It hasn't been something that we've focused on for in terms of the sort of complement pathway in that CMS4 subtype. Sort of that opens up a whole other domain of the role of the immune system, you know, in cancer progression. So for this purpose, we chose to focus specifically on that sort of stromal compartment.
Thank you very much. So this concludes our scientific conference. We plan to have this every 6 months, but you can see from the presentations that maybe we're pressing our PhD students a bit too apart, and that is to present real-time data. So maybe what we'll do is have the scientific presentations at our annual conference, and then after 6 months, so alternated 6 monthly, with maybe a presentation from their supervisors, and this could take a whole different sort of perspective, maybe more of a personal view on how research is developed, or maybe bring in even other work than just basic or clinical research. I thank you very much for listening, being present. I thank the presenters for brilliant presentations, and of course the supervisors for all that work they've put into stimulating the respective PhD scholars. So this concludes the scientific part. We'll have awards at the beginning of our community meeting, which is at 4:30. You're all welcome to the public part of our Sydney Bible Conference day. And for now, I thank you once again, and there's tea and coffee at the level 5 foyer. Thank you very much. Yes, but not in this room, it's in the auditorium, the public report.
Also, we can let you see it as well.
I thought the word primary correction. For the beard on that.
It's pan-cancer.
There was a low primary colorectal in the talk, right?
Pan-cancer. Oh, wonderful.
So, how are you doing?
Yeah, good. The technical part of the, so then, I'm not even, I know the gene expression stuff, getting find out.
Yeah, there's a signature on the right.
Yeah, I've got all 5. But you can't just take the whole away. Get the research separated from just
Same as the head.
So it's not simple. You have like So,
Yeah, I know you do.
Simone, I know you
I think that would be a good time for us.
Yeah.
I did time penalties. Yeah, well, I might be need to actually start.
Yeah. Why? Yeah. This is what this is the
So 6. Yep. Nobody else has done anything like this.
no matter. Well, what we said.
That's right. There are in the cancer rates on states that exploit that indoor so and also I think it's money I always think that it's like coming from the Birmingham you know, massive map and all that. Still don't really understand why, you know, exactly
Why did I find it?
Judy Cole, is that right?
I'm not.
Oh, something like that. So you also,
Yeah, I don't think it's more necessary. Yeah.
yes. Okay, so things isolation, what the friend, taking a population of Oh, no, absolutely. So I'm very interested in cell analysis, so, and,
Yeah, well,
I'm doing so, the postdoc you were doing, what were the questions you asked? Are you an engineer or
it's almost. Yeah, I like it.
They're very specific.
Yeah, it just shows more respect that they're taking this topic. And it's part of that comparison clause. No, I had a big bunch that had the same score. Yeah.
At the moment, a lot of them going on in single analysis using microeconomics, a lot of microeconomics stuff. And one, it's outrageously expensive. Two, even just bloody complete.
No, I actually, when we put everybody, I actually scored her quite highly in the other chapter.
Yeah, but I think
But I have gases. I can't actually score Chris, I guess, because I feel like it's, yeah, I mean, his communication skills are but in terms of collaboration, outside.
yeah, so it's
For me, someone like
one, it is a big area where a lot of people also methods in life. The vast majority of kids, it's probably maybe up to 600.
and
Certainly, we know.
yeah, I guess
Stated from stiffness
board, claims board,
the impact that is a cap around the tube, which is the urine, and so people are trying to say those
it's hard because if you don't have a background in the area,
and they do
because I know it
create stress response and that's how it's slowing out. They can
it's hard to take them report.
and the other one Bristol. When you start to see
And I know that she knew that I'm way more no notes. Yeah, I had so
all that finally
I had a 3 around the third, but I think from the 3 I did also no, I can watch it.
oh, I'm sorry. Yeah, so when you have a single cell bladder bloodstream, because there's almost a patient and you can isolate the there is a big debate as to how far you can go.